given me the conviction to move forward on the healthcare delivery science. And we've had some successes already in improving diabetes care and reducing amputations. I think this is a real opportunity for people on our faculty to do research that isn't mice and test tubes and genetics necessarily. This is research that when you do it and when it works, you can see the real world impact and patient outcomes and how efficiently and effectively care is delivered. So I'm very enthusiastic about this. The school is enthusiastic to the extent that in addition to the core in healthcare delivery science that we have as part of the CTSI, the school's invested another $1.5 million to set up a full center for healthcare delivery science with more education and more different funding opportunities and seminars and things like that. So I would say the Keck School is all in on this, and we really look forward to another good year of these things. The pandemic's kind of hurt us a bit, but the 3 years before that, I was very proud of the work people did. I mean, I think it's been good for our faculty. So that's how I'm starting this out.
Yep, thank you. And I'll just, I mean, I think just to pick up on your comments, Tom, you know, it's so important that we think about research as having real world impact. And what better way to do that than to think about how we are looking at real world healthcare delivery settings and how we think about bringing what works to our patients. So, you know, this is such an important partnership, our relationship, both USC and UCLA with the Department of Health Services. And I think what an extraordinary opportunity to bring all of the talent together across these institutions and to support the work of our investigators at both, you know, in those settings and also at DHS. So I'll stop there.
You know, I guess I would like to start by, you know, telling everybody that I can't tell you how much I appreciate the partnership with USC in trying to think about how we improve our ability to deliver care. As somebody who spent the first half of my career as a laboratory-based scientist, in addition to being a physician, I was, I guess, fortunate to have the opportunity to see that, you know, the most important thing we can do is to improve care of our patients. And that in a couple of years, I made a much bigger difference in many patients by trying to improve healthcare delivery than I had in 20 years doing basic science. That's not to say that if somebody is passionate about basic science, they shouldn't do it, but it's to say that so many of this generation's emerging investigators in medicine are interested in making a difference for patients. And if you are actually interested in making a difference in patients, I challenge you to actually make a difference in patient care. I would say that that's probably the single most important problem in American medicine. I think the pandemic showed us how critical it was, going from amazing use of basic science principles to develop vaccinations faster than ever, and then to get to the frustration of nobody wants to take it, we logistically can't give it. I think we now need to realize that the delivery care is so important. And one of the things I've always mentored, whether I was in the lab or in my current role, mentored emerging investigators, is you got to take advantage of your competitive advantages. Investigation and a career in research is so hard and it's so competitive. And if you're going to compete, you got to take advantage of what you have. And you know, I think Tom and Michelle and I are so proud because we have a unique competitive advantage here with the engagement between USC and DHS. You know, I guess it's quasi-unique because UCLA we also work with as well, but this is a unique competitive advantage that you can't get anywhere else. And I just advise you to take it. So I guess I'll end with that.
Thank you.
Thank you, Dr. D. Shifting back to the slides so we can share some of the details of this unique award. Take it away, Tom.
Yeah, okay, so I hadn't heard of healthcare delivery science until we started all this, and some of you might not have either. So just to bring you up to speed or refresh you, It's a study of systems, processes, leadership, and management to optimize healthcare delivery and then health to all. It focuses on improving health by improving systems of care. So the outcome is better health, but the methodology here is systems of care and care delivery. And we seek to ensure that patients receive recommended therapies by changing clinical behavior. So some of that is directed at physicians, by removing barriers to access to care, improving teamwork and culture. That's one of the real critical components, and I think one of the strengths of this program. People from the USC side paired up with clinical leaders and care providers on the DHS side. It's one of those unique opportunities that Hal just talked about. Measure and provide feedback about the performance, does it work or not, and create incentives for clinicians and patients to encourage desired behaviors. So basically, it's a lot of, we're not limited to those, but those are a lot of the types of things that we use in this healthcare delivery science. Next slide. The Safety Net Innovation Awards are there to advance innovative research to improve the delivery of care, thereby improving health for individuals and populations, in particular in the DHS. Now, we do have plans when things work to adopt them in other health systems. For example, the diabetes outcomes that we demonstrated, reduced hospitalizations, reduced ER visits, and better A1Cs, we're now applying that at CAC and at Children's Hospital. So we have 3 different systems we work with our CTSI, but it all starts with doing our research with our partners at DHS. Project requirements for the Innovation Awards: you need to test a solution for a bona fide problem within healthcare. And Hal's going to talk about what some of the high priority problems are in DHS. They should be aligned with DHS's specific infrastructure, business approaches, and operations, because these projects will be conducted within and across DHS. CTSI and the Keck School of Medicine are putting in money, but DHS is putting in very valuable resources in kind, people, places where the research has to be done. And those are the same places where the care is delivered. It involves broad participation across sites and disciplines. So this is the ideal projects really can be done across DHS, as Hal will probably tell you. And they're focused on effectiveness. And I think this is one of the biggest areas of confusion, but most important points. That is whether an intervention works in real life as opposed to efficacy. So when people do randomized clinical trials in very controlled situations, you can demonstrate the efficacy of a behavioral intervention or a medical intervention or surgical intervention. That proves it works under those controlled conditions. But in order to have it work in the real world, you have to demonstrate its effectiveness in that setting. And that's what this program is really about. It's designed to improve patient access to care, quality of care, and eventually health outcomes. So what's a bona fide problem? An evidence practice gap. So we know it works, but it hasn't been implemented in practice. Practice approach that will improve quality, access, and outcomes in healthcare delivery. Some examples: applications of virtual care, ways to improve access to care. We've had some proposals on pain management, on medication compliance and cost efficiency. Preventive care, you can see a long list of those things there, and patient engagement. Again, these are just some examples. You may come up with something that's not on this list that you want, that is efficacious by controlled clinical trials, but that you want to test for efficacy with your partners at DHS. Next slide. And I alluded to this already. These awards leverage infrastructure at DHS, 4 hospitals and hospital-based clinics, plus ambulatory care network of 26 centers. Partners that have worked closely with this program are the primary care work group, the specialty care work groups, inpatient medical directors, and the outpatient primary and specialty medical care directors. So those are really the leads of all of the care delivery components across DHS. Health information management works closely, and the CTSI has 2 people who are embedded within the IT group at DHS to help get data for outcomes or enrollment, things like that. And then the team's working on paper performance metrics, including prime, quality incentive pool, and other cost-effectiveness activities can be involved as well. Because in the end, while the primary focus of these is to improve patient outcomes, we want to know, is it at a huge cost or a reasonable cost? Because if it's at a huge cost, it's going to be hard to implement. But if the cost is reasonable, then the cost-benefit ratio becomes reasonable as well. Broad participation is encouraged. So I alluded to this already across The 4 hospitals, the hospital-based clinics and ambulatory care network, and multidisciplinary interventions are almost always involved here because of the complexities of healthcare delivery. This focus on effectiveness, I want to reiterate that efficacy is a performance of an intervention under ideal and controlled circumstances. Randomized clinical trial that we all learn to do and instinctively think that's what we're going to do here, but that's not. We're looking for effectiveness, the performance under real world conditions. So efficacious interventions must be readily available. Providers must identify the target population and recommend the intervention, and patients must accept and adhere to the intervention. Again, this is going to be in a real world setting. So for those of you who have grown up with a lot of scientific rigor, it might feel a little bit uncomfortable. There's not necessarily going to be a control group. There's going to be an implementation and see what happens over time. Poor access, recommendations, acceptance, and adherence rates can lead to highly infectious interventions being less effective than in practice than less effective, less efficacious interventions. What that means is there's a lot of reasons why something that works in a controlled clinical trial might not work in a clinical setting, a real world setting, and we need to make those things work. Next slide. The key features of the grant. The use of funds is intended to test effectiveness of an efficacious intervention in DHS. It needs to be implemented broadly across the system. Strategy needs to be congruent with the health system operations. So if it's something that can't be done within the way the health system operates, it's not going to be useful or implementable there. They're designed to improve quality, access, and outcomes of care, engaging stakeholders. So that means engaging stakeholders on the academic side and many stakeholders on the DHS side, from clinical care leaders down to the on-the-ground clinicians and support staff. And people who have these awards will work with a mentor team, with mentors from USC on the academic side and from DHS on the side. And the technical details. I think, Allison, you wanted to switch over and take care of this, right?
Sure, thank you, Tom. And so to all the potential applicants here who are interested in applying for an award, this is an important date. So about a month from now, Monday, May 30th, we invite you to submit an LOI, and that's a required letter of intent for this program. And in advance of that date, so over the next month, we invite you to work on assembling your teams, a multidisciplinary team involving DHS leaders. Take the online course that I'm about to show you in healthcare delivery science, and upload your letter of intent through a form that you can find on the RFA. After LOIs are submitted, a review team will invite from among those letters of intent who to invite for us to submit a full application, and that deadline would be September 1st. The award is open broadly to any faculty member at USC. These awards this year are larger than in past years and longer, so up to $150,000 over a total of 2 years.
And before you go on, Allison, I just want to emphasize that this is very much different than the way we usually run pilot programs, where we just send out an RFA, we see what comes back in, we score them, and we give out some of the money. This is, I think, a much better way to go about things. This starts out with understanding what the issues are in DHS and the opportunities are. And then you have an opportunity to build teams with input from the program, input from the DHS side, put your team together and really come up with something that's realistic from the testing the efficacy side, as well as from implementing in the DHS side. So we've got all these steps in here because this is really about team building and understanding the problems and really then selecting the best things that come to the surface. Go ahead.
Thank you. So the course that we talked about is online and self-paced. You may request access to it at the link at the bottom, and view the intro lectures in advance of submitting your letter of intent. So this will give you some of the basic principles of the different disciplines that go into healthcare delivery science. And we highly recommend that you complete these, including the quizzes, before submitting an LOI, and weave some of these principles into your project proposal. If you're selected to submit a full proposal, we require that you at least complete these introductory lectures. And the full course, which is these intro topics, plus a number of other topics, will be slowly rolled out over the next few months. And we will require that the awardees complete all of those lectures.
And all of this is because we've noticed that people really don't understand healthcare delivery science. I said that I didn't know anything about it before I got into this. And we, in the past, have gotten a number of proposals that really aren't about efficacy. They're about, I'm sorry, really aren't about effectiveness. They're about efficacy and randomized control groups and things like that. You need to understand what this discipline is really about. We've had a lot of faculty members from many schools at USC help put these together. They're well worth reading if you want to understand this discipline, and eventually will require them as you get farther and farther down the line.
Thank you. And here is a list of the mentors who are willing mentors, willing to be contacted and invited to be collaborators on your projects. From the DHS side on the left, as you'll see, a lot of leaders who are well aware of the issues and opportunities and priorities at DHS. And on the right is where you'll find not only USC, but also Brian Mittman is from Kaiser, who's a specialist in complex interventions. Any of these folks are enthusiastic about being contacted by potential applicants and discussing how to improve the methodological rigor of your project. And so please take advantage of this. And we have a few on with us today who please take a moment to introduce yourselves. I think I saw Dr. Wu and Dr. Sui.
Yes, hi everyone. So my name is Shani Wu. I will serve as one of the research mentor, and I'm trained as a system engineer, have over 20 years experiences working on health service research. So in my course, you'll learn about system improvement processes and the tools, including Six Sigma, Lean, and so forth. So I welcome you to take a look of the intro course, and feel free to reach out to me if you'd like to discuss more about how systems engineering can be applied for the topics of your interest.
Thank you. Jen?
Sure. Hi, everyone. I'm Jennifer Sway. I'm an associate professor in the Department of Population and Public Health Sciences. Most of my work focuses on healthcare access, quality, and outcomes related to safety net populations and cancer. So I do a lot of work looking at primary care to specialty care transitions, quality of care among racial ethnic minority patients, and guideline concordant treatment. I am a health services researcher by training and have moved quite a bit more into the mixed method space. So a lot of qualitative data collection, as well as use of administrative claims data and EHR data to understand sort of patterns and barriers to high quality care. I am in the process of working with the center to develop a stakeholder engagement training module. So that is still in the works and soon to come.
Thank you, Dr. Sway. Dr. Mahajan, would you like to say hello?
Yeah, hi, everybody. Nice to see everybody here. I'm Anish Mahajan. I'm the CEO and the CMO at Harbor UCLA. Happy to talk to folks as their interests may drive them on their projects. I'm also somebody trained in health services research as part of the RWJ Clinical Scholars Program back at UCLA. Happy to help.
Thank you.
Thanks to all of you for attending.
And I also see Dr. Wendy Mack, the Director of Biostatistics at the CTSI. As you'll see in the RFA, we highly encourage folks to request a consultation in study design with Dr. Mack and her team prior to the full application submission. Wendy, if you'd like to say hi, you're welcome to. Otherwise, we can move on.
I'm not planning on saying anything, but I just wanted to listen in on the orientation for investigators. So I would, when they do come to me, I would know what they've been told. So yeah, I welcome everybody. I know many of the people on this call, but yeah, I welcome anybody who has any issues on study designs, sample size, etc. you can make a request to the Biostatistics or BIRD unit through the CTSI website.
Terrific. I would invite folks, if they're willing, the mentors to put their email address in the chat so that potential applicants here can contact you if interested. And I'm also putting the link to the course that's recommended prior to LOI submission in the chat. All of this information is in the RFA as well. Okay, thank you. Great to have everyone here. And moving on to the fast pitches. So this will be a fun time to hear from potential applicants. I invite you to raise your hand if you would like to present your project idea. It doesn't have to be fully baked. This is a time to get some immediate feedback and potential pointers and introductions from Dr. Yee and others. And so I'm looking for hands raised virtually, or just introduce yourself if you're not sure how to raise your hand.
If people are thinking, Allison, I'd be happy to give a brief, I guess, advice on picking a implementation or health services delivery project.
Terrific.
So, the first thing is these are problems that are real problems. And you're not going to learn about real problems from your academic mentors, and you're not going to learn about real problems from the literature. So, I'm being a little, but not very provocative when I say that. Pretty much ignore your academic members when they come up with ideas for you, and ignore what you read in the literature, because we really want real world problems. We don't want the incremental next problem that helps somebody else's career and idea. So how do you do that? For those who are clinicians themselves, the best thing to do is think about the work you've done as a clinician, taking care of patients or clients, and what has frustrated you, right? Where have you just said, why do we do this way? Or, how come this is so slow? Or this seems like such a waste. Those are really good places to find problems. If you're not a clinician, then think about your or your own family's healthcare. And where have you been frustrated? How come this doesn't happen? Gee, this seems so obvious. So those are the real world problems. Then the next thing to do is to take that problem, and then you have to do a little work and figure out, where's the bottleneck? Where's the rate limiting step? Where's the root cause of that problem? Because what you see could just be, what frustrates you may be a symptom of something that's underlying, and your goal is to find that thing that's underlying. And then the final advice I'd have is, at least with regards to picking projects for DHS or for this program, think about impact on them, the biggest impact on the most people. Right. So whereas a lot of the traditional research is, let's find something really rare and really serious and spend, our time working on that. Ideally here, it would be, let's find something that's done very commonly and doesn't, and we can fix that very common but seemingly minor thing, because that will translate to lots of people's improvement in their healthcare. So anyway, I'll stop there, Allison.
That's terrific guidance. Thank you, Dr. Yee. Any brave souls ready to pitch their ideas or ask questions? Jin, take it away.
Hi, everyone. My name is Jin-Sol Lee. I am a new faculty member here within the Department of Internal Medicine. I currently work as a hospitalist. The idea I have came from a bridge of my own lived experience, taking care of my stepfather, who had suffered a heart attack when I was a medical student, and having to navigate his care, and then the challenges that we had kind of faced on his discharge. And I ended up pursuing a more entrepreneurial route, where I tried to work with my team to develop a virtual cardiac rehab platform for post-MI survivors in particular. finding that the need was really high. So about like 7 million patients around the world and about 1 million patients in the United States alone are hospitalized annually for treatment of acute myocardial infarctions, and finding that adherence was a huge issue. Just adherence to dual antiplatelets alone at 12 months was about 15 to 20%. At 30 days, about was lower as well, with the concordant risk for mortality. So, virtual cardiac rehab is not new. It's being done by other startups and companies. But I think one of the things that draws me to this project is how can we actually implement engaging and empowering platforms for patients using participatory design. So using investigation of the lived experience of the patients themselves from different backgrounds, from different socioeconomic backgrounds, to ensure that they have equitable access, and doing that in a safety net setting, while ensuring that the stakeholders in the DHS system also have aligned goals and priorities. So the ultimate goal is to create kind of an autonomous platform that can provide assistance, especially at a critical time from hospital to discharge, hospital discharge to follow up for patients. And using like the participatory design principles initially to investigate those things, and then developing kind of like a chatbot type of mHealth platform to actually bridge those gaps. So that's kind of the general idea I have so far.
So I love the problem, right? It's big scope. It's really important. I love the fact that what you're talking about is a relatively simple solution to a big complicated problem. But what I would do is say, okay, focus on the problem. Now, everything that you're anchored to, all of your own personal ideas that sound really cool, I think you have to sort of suppress your ego about your own ideas here, which it sounds like you probably will, because you didn't do this for yourself. You did it because of your personal lived experience. And I'm going to tell you that you should talk to these individuals for these different reasons. And I think you could really develop something amazing, both from an academic and possibly a commercial perspective. So first, if you want to do this in the DHS, this is in no priority, so just write down the names and the reasons, and you just should talk to all of them. Is first, for post-cardiac rehab, there are two people that you absolutely have to talk to and think through with. So Amy Tofigi, who you may or may not have talked to already, you should, because that's been a lot of her research, is people who've had stroke or heart attack, MIs. How do we think about their post-care? So talk to Amy. She will have a lot of ideas. She has worked at both Rancho Los Amigos, a rehab hospital actually, and at LACUSC. So she can connect the academic part to what actually happens in real life across DHS. So that's one person to talk to, and that's to get ideas both academically, but also clinically, operationally. Next person to talk to is Cesar Aranguri. He's the chief of cardiology at Rancho Los Amigos National Rehab Hospital. Cesar has developed a real live therapy based, in-person therapy based cardiac rehab program at Rancho Los Amigos. And, it's great that you have a platform and it's going to be self-service, it's going to be electronic, but wouldn't it be great and critical for us to take advantage of the fact that we have one of the best therapy hospitals in the whole country? So you should talk to Cesar or whoever Cesar connects you to, so that you can think about it. Rancho Los Amigos, what are the actual cardiac rehab resources available? I think you also have to talk to our IT team. You should talk to Phil Gruber, who's the interim chief health informatics officer for DHS, and to Rami, and I forget, Anish, what's Rami's last name?
Anish had to jump off.
Oh, okay. The chief medical officer at Harbor UCLA is actually the leader for our real-time video program. So whatever you're doing in terms of your platform, we'll kill a standalone thing that you want to do with us. It's just dead on arrival. So if you have something, the goal would be, how do you take the functions that have been important or you think are important, and how do you somehow integrate it with the work that we're doing, right? It's got to connect in some way. I mean, the platform doesn't have to go away, but it has to connect to what we're doing. It can't be standalone because we just won't support it. And then the last thing, and I know you're a hospitalist, and I know you probably think about the discharge, but DHS is really a system that cares about our assigned and paneled patients. We take care of people in the hospital from all different systems. And so your project, although I'm not averse to it helping people who are being discharged from our hospitals, I care much more about using your system or adopting your system for the care of our impaneled population who get hospitalized at both our hospitals and outside hospitals. So for that, I think you probably need to be talking to Evan Raff, who is on that list of mentors. He's our director of specialty care. And probably at some point, Jagruti Shukla, who is our director of primary care, because I think this has to fit. It has to serve our impaneled patients, not just our hospital patients. So I'll end with that. So Jen, I think this is a really exciting idea. And I think that we could probably do this if you're willing to take your terrific idea and problem and do the hard work of delivery science and implementation, which is to take a real world health system and adapt it to what we need.
Great, thank you so much.
Thank you, Jen.
Oh, the other thing I'll say is historically over the last 6 years, and I'll do it this year, if any of you want to send me an email, I'll give everybody an hour. And you can talk to me one-on-one for an hour and I'll work through this stuff with you. There are no guarantees for further hours if you're not like into this, but I'll give everybody an hour.
That's very generous.
Thanks.
Any other takers right now?
Is it too mean if I pick on somebody who I don't even know?
I don't think so.
Well, I'm going to ask
Real.
her. So, Callie, I'm an ASLD member and I saw your survey request. Do you mind if I don't know you, I've never met you, and I don't actually know your project or reason you're doing it, but it's kind of it could be a good model for me to sort of explain the difference between traditional health services and the delivery world, but I don't want to pick on you without your permission.
You have permission to pick on me, but I wasn't so prepared that I could pitch my idea, so I was a little worried about that. But go ahead and go ahead and pick on me.
So to give people context, and I'm not meaning to be mean or rude. I tend to be a provocative person, so I'm going to push buttons, and it's all in sort of the fun of, by being provocative, sometimes people take things away from meetings that gets less boring. So Kali apparently is doing a survey with the ASLD, at least with their email list, right? So sending out an email to all the hepatologists in the country and maybe internationally, asking what they see as the barriers to transplanting, liver transplants in the safety net. And I'll tell you, Kali, it just triggered me. I actually sent it to Tom and to Allison saying, what's wrong with this person? And I was doing it facetiously to make a point, which is, we don't need survey. You could work in the safety net. You could partner with the largest county health system in the country, in LA County DHS. We'd give you the keys to this kingdom to reduce or to improve liver transplant in our system, which is a reduction in inequity. And I don't need, and you shouldn't need, a survey to do this. I have met with at least 24 junior faculty, fellows, or residents over the last 20 years who have wanted to do some sort of survey or study to either determine or understand what the challenges are causing inequity in patients with liver disease. And I say the same thing to every one of them, so it's not personal to you. Why would you waste your time doing something so dumb?
Well, in my defense, I agree with you that within LA County DHS, there's plenty that I'm aware of and that I better understand the barriers. It was, I guess, a little bit more pinpointed to the fact that I think the experience is different across the nation. So understanding more of across different safety net settings.
Yeah,
that's more what it is. Yeah. And
this is why I said what I said about not talking to academic members about this kind of thing, academic mentors, because I used to be on study sections. I used to do all of this stuff, and the problem is there's almost a cookie cutter thing for junior faculty in liver disease. You can talk to your cohort, you can talk to people 5 years ahead of you, and I bet you half of them did some sort of survey or some sort of thing trying to look at equity. It was always in the preliminary data. They did the abstract. If they were really good, they actually got it published. And it didn't actually change anything for patients. And if, another thing I said to him, which was, I think, kind of ironic, was I said to Tom and Allison, and the sample size is going to be crappy because I'm a hepatologist and I'm not going to fill this thing out. And sure enough, when Tom sent it to you, you were very happy that it had some circulation, which is really good, but it's also predictable that you're going to get a certain kind of person, and then we don't have to go into who that person is going to be.
agreed.
So to make this more general for people and not so picking on somebody, here's a junior faculty member who's doing a very traditional thing that lots of people who have become successful have done. And a lot of those people haven't, in fact, made really any significant changes in healthcare of our patients with liver disease, even though they've got lots of grants and papers and all of that stuff and got very famous. But the whole point of this work is not to get famous. It's maybe you could get rich. As Jin is pointing out, this is an area where you could actually commercialize. So I'm not against people who want to get rich, but it's probably not a place where you're going to get famous, because you get famous in medicine often because you come up with an idea. And then you take that idea and you don't let anybody else have that idea, and you hog the credit for that idea. Right? And that's why the efficacy stuff doesn't translate to effectiveness very often, because people who are doing really good randomized controlled trials have to worry about their data and have to worry about getting published in a journal that has a statistician looking at your data. And so it has to be so perfect that it doesn't actually apply in the real world. And then once they do it, they have no real interest in messing it up by doing it in the real world. So the interesting thing is, to do this work, you don't have to be creative about a new idea. You can borrow the efficacy stuff that's published. And then the important part is, how do you take that, understand the health system well enough to apply it so it actually gets to our patients? And I will tell you that if you took me up on my hour, I could tell you what all the problems are in liver transplant and why there's inequity and where all the problems are. And I actually think that some, but not all of them, you could actually write this grant this year, and you could actually solve a real world problem for our patients getting access to liver transplants by 2 years from today. And I know that the tendency is to think a lot and talk to people and try to learn. But the reality is, you know, the thing with liver transplants is it's actually pretty easy to understand. If anybody is doing EDIA work, and a lot of people who are in this sort of field of improvement in health care also think about equity, you know, diversity and inclusion. And if you applied all of the EDIA thought processes, what you would realize is that people who get liver transplants fall into all the privileged categories. In fact, if you don't have privilege, you don't get a liver transplant. And that's why these surveys are ridiculous, because if you look at who the transplant have, if you look at a transplant panel, you see people of privilege, you don't have inclusion. Anyway, I won't go on a rant, but I wanted to use this example because some of the rest of you are probably thinking along these same lines. And what I'm trying to do, what Tom's trying to do here, what Allison's trying to do, Amy's trying to do is, and Michelle is, we're trying to get people to take their brilliance, their intellectual rigor, right? Their research methodology and understanding. And how do we take their time and energy and their passion and translate it to this kind of work? And the crazy thing I want to share with all of you is it's so much easier to quickly make a difference in this kind of work than it is in the more traditional academic approach. As I said, I spent 2 decades doing research in the lab, made no difference. And I don't know if anybody here uses electronic consultation or e-consult, but I took the idea, my idea of e-consult, and I implemented it in 6 months across the entire safety net of San Francisco. And in 2 years, we implemented across LA County. And, you know, it's just a lot easier than understanding the signaling pathways that underlie cirrhosis. So I'll stop there. I don't know if you have anything, Kali. I should give you a chance to respond. And if anybody else, you know, wants to raise their hand.
No, I think what I just say is that don't worry, I'm gonna set up that hour with you, Hal, so we can discuss. You know, liver transplant's part of my interest, but I'm really interested in liver cancer and sort of getting, you know,
same thing there. You can't get, yeah.
Yeah, exactly. And so this is like exactly what I'm interested in. I really want to, you know, improve, sort of optimize the safety net system for liver patients, but specifically related to surveillance in transplant. So anyways, I will set up an hour to chat with you.
Great. Look forward to it.
Thank you for being a case study. This video is being recorded and will go on to the website after the RFA, so others can also hear this real talk from Hal. We did have one other potential applicant. Stephanie Moon, are you still with us?
I'm still here. I'm getting real nervous, but also really excited to share kind of my idea after hearing the feedback from Hal. But so I'll get to it. My name is Stephanie Moon. I'm an occupational therapist by training with a single-minded goal and interest in working with persons experiencing homelessness. My professional experiences have really had me working in FQHCs with a homeless healthcare designation, permanent supportive housing settings, as well as medical respite. I'm currently an implementation specialist at UCLA, sorry. But I did go to USC for my OT training. And our idea, it's again, still a little nebulous. I was chatting with Allison. It's still forming and I'm still kind of wrapping my mind around it, but I wanted to take advantage of the direct feedback being provided. So I think that the project goal I had in mind, that we had in mind, because I actually have a few collaborators, I'm just here as the person gathering information, is really to improve access to care, quality care, and health outcomes for persons experiencing homelessness that are impaneled to DHS. And I think from right, the problem statement perspective, persons experiencing homelessness have challenges with self-management around chronic conditions, specialty care access, navigating systems of care for a plethora of reasons. I won't go into those, as well as obtaining and maintaining housing, appropriate housing. And we know that housing has a direct impact on health, right? So that's kind of the general problem. And I think in terms of the idea or the program idea is really to create a clinic-based and a mobile program of interdisciplinary team members that might consist of primary care providers, nurses, OTs, of course, case managers and social workers who can kind of, again, support the client when they're in the clinics, say the STAR clinic, right? But also to go to individuals wherever they may be, if they're in a permanent supportive apartment unit, at an ERC boarding care type unit, if they're in the hospital or if they're even dwelling on the street. So really being able to wrap around this individual and again, help them improve their access to care, the quality of care that they can get by advocating for them, for instance, and so on and so forth. So that's kind of the general gist of what I'm hoping to do and study the impact of. In terms of like stakeholders and things that I've thought about or that I'm in cahoots with, that might be folks at Housing for Health at DHS. And then from the USC side, of course, the Chan School of OT and OS, Deborah Pitts has been my long-term mentor. So those are some folks that I'm kind of thinking about in terms of pulling in to really understand the issues and the practice realities and things of that sort. So I'll stop there because I feel like I've been rambling a lot, but I'd love to get feedback on if this seems like something that would line up in terms of a priority project, if it would make sense with this grant.
So first I'll say my sister-in-law went to OT school at USC.
Oh, okay.
Can I ask a question? So obviously you have an OT angle.
Mm-hmm.
In your investigator hat or implementation hat,
Mm-hmm.
is there a particular angle you're interested in? Is there either a method or a way of thinking or approach?
Mm-hmm. So I think that's part of the challenge. I mean, looking specifically from the OT perspective, the literature is not very strong in terms of the different, right, like research evidence-based approaches. There's not a specific intervention that has like step 1, step 2, step 3 enumerated for this type of a collaboration. So, I mean, I think in the literature, there's certainly roles for OTs as a care coordinator. There's certainly roles for.
Let me be more specific. What's your skill set other than being an OT?
My skill set other than being an OT?
Yeah, other than OT. Do you do statistics? Do you do design? Do you do qualitative?
No, I mean, I think one, I am an OT by training. And then in terms of, I've done like program design. I've piloted some programs in primary care and medical respite for OT. And then in terms of from an implementation side, it's mostly been doing some research. So some qualitative research for my current clients, as well as some quantitative design. But I think I would probably be looking to have help around kind of the statistics, like the designing of the research component, and really articulating kind of what the intervention is, if that makes sense.
Okay. So in your case, well, absolutely, right? I mean, the healthcare of homeless folks, homelessness is a tragedy, and the healthcare adds to the tragedy. And we need as many ideas and ways and approaches because obviously we don't have solutions. So this is where I would say that you'll have to suppress pretty much any ideas you have, except that OT may have a role here. Because, you know, as you pointed out, this is really a team approach. And I'll give you a couple of names. The first person I'd start talking to is Heidi Befarouz. Her last name is spelled Behforouz. And Heidi is the medical director for our Housing for Health program. There is no more passionate and knowledgeable clinician around homelessness probably in the entire, you know, well, I know there are a lot of good people, but she's right at the top of people in the country who thinks about it and does it. So I think the place to start when we're thinking about effectiveness in real world addition of OT modalities would be to talk to her, because she basically runs the program and takes care of these patients. I think from her, you would probably want to be connected to whoever is, operationally thinking about, our approach. I know at the top, and if you can get time from him, he's very busy. It might be worth trying to get a hold of him. It's Clemens Hong, H-O-N-G. Clemens is actually the director of the community programs in the Cal Ames project. So if you don't know what Cal Ames are, you probably should go Google C-A-L-A-I-M, Cal Ames, and it's the new California 1115 Medicaid program. It's going to be worth hundreds of millions, if not billions of dollars, and is focused on sort of whole person care, including folks who are homeless. And in your particular case, I think that, yeah, it's great. Everybody wants to think about how are we going to do this. There's no way you can do it from your platform. But what you could do is serve as the person who brings an understanding of occupational therapy tools and other therapy tools to homeless people. Because I'll tell you this, physicians are terrible. We don't know anything about therapies. I mean, I didn't learn anything. I learned a lot from my sister-in-law, and I learned a lot when I was the interim CMO at Rancho Los Amigos that I never knew in my life. And, we know more about PT than we know OT, and we don't know very much about PT. And there are skills there and tools and modalities that OT can offer, I think, to this. And so I think that would be sort of your hook. And insanely, if they have any vacant positions, maybe the most important thing if you want to achieve this would be if they have vacancies and they're hiring, they may not be hiring OT, but they may be hiring somebody who you could fit into the role, because that's, we have, again, the biggest county program. They're probably either the first or second most homeless people in the country here in LA. And we're going to have hundreds of millions of dollars available to take care of these folks and their health care. And, if and you may be the only occupational therapist in the world who wants to do this, if you could get plugged into the team, the sky's the limit.
Right. And, it's, I really appreciate that feedback. And, while I'm an occupational therapist, my passion is working with this population. OT just happened to be my venue. And no, this is great. And perhaps, Hal, if you're open to it, and it sounds like you are, I might take you up on that.
Yeah, we can talk.
Because I am kind of in touch with some of the parties that you're mentioning and trying to wiggle my way in there on the team. So I'd love to strategize with you a little bit more.
Great.
We have time for one more mini pitch if anyone else has one. If not, let's take these last couple minutes to introduce Brian Mittman, who just joined. He's another potential mentor for applicants. Brian, thank you for joining.
Sure. Sorry to be late, but glad to listen to at least a few minutes. And I welcome any outreach.
Thank you. Brian, if you could say a little bit about your expertise.
Sure. I'm based at Kaiser Permanente, Southern California primarily. Main focus is implementation science, but more broadly healthcare delivery science. And I have a special interest in complex health interventions, those that are multi-level, multi-component, highly adaptable, and not appropriate for evaluation designs that basically attempt to answer the question, is it effective? Because the answer for these is always sometimes or it depends. So, sort of the process evaluation, mechanisms of effect focus, those are really the areas where the methods that I deal with are most applicable. And, appreciate the opportunity to support, this program, which is critically important.
We appreciate your involvement. Brian, if you could kindly add your email into the chat so that these potential applicants can contact you, that would be wonderful. Any other closing thoughts from our esteemed leaders? Tom, you're on mute.
I just wanted to say thank you for everybody that participated. For those of you on the potential applicant side, share it with your friends. We would like to see even more. So please do that. We want to make this program grow. We want to make this a discipline that people are quite familiar with across medical school and certainly in partnership with LACUSC and the DHS.
Yeah, and I'll just add, I'm glad you're here. I'm glad you're interested. Just to pick up on the conversations and points that Hal's made, this is probably the most impactful work you could be doing right now. So I couldn't encourage you anymore to be doing that, to really be thinking in this space. It's hard space. It's not easy. It's not for the faint of heart, but this is going to be where the most impactful work is done. So I appreciate that you're here.
Thank you, everyone. Take care, and I look forward to seeing those letters of intent. Bye-bye.
Bye.